Hello, my name is Maitland. I am looking forward to talking about some observations that we've put forth regarding immune dysfunction that appears to be common in individuals that have hypermobile spectrum disorder and Ehlers-Danlos syndromes. I have no disclosures for this conversation. And I like to start off by saying mast cell activation disease is common. 1 out of 5 individuals deal with urticaria and angioedema at some time during their life. There's a growing number of individuals that have food allergy and intolerances. 1 out of 11 of us may have asthmatic-like symptoms, and nearly 40% of us are dealing with upper airway inflammation. So when individuals present with these symptoms, whether it's headache disorders or fast heartbeats or gastrointestinal distress, we typically will do allergy testing. But that completely ignores the other receptors that are on mast cells that try to sort out what might be coming into the body and potentially causing problems. So to kind of give you an idea that mast cells are more than a one-trick pony, I wanted to illustrate some of the receptors that we know the mast cells utilize to do surveillance and respond to impending dangers. There are direct receptors such as the toll-like receptors and the receptor, the MERG receptor for short, that recognizes medications such as fluoroquinolones and certain antibiotics and anesthetics. But then you also have the indirect receptors such as the immunoglobulin receptors. And you can see, depending on what receptor is engaged, you can have different chemicals that are released during degranulation or de novo synthesis, all depending on the combination of receptors that are engaged on the mast cell sitting in the connective tissue. Just to give you an idea of all the different ways mast cells can be triggered to release their chemicals, this is talking about a very common skin mast cell disorder, urticaria and angioedema. And the lower right-hand corner is an individual that actually has cold-induced hives. So you could have physiological triggers like temperature, sunlight, vibration that can cause your mast cells to degranulate in the skin, or you may have allergies, you may have an undiagnosed immunodeficiency, coping with a chronic infection, or have a drug allergy that can cause the same type of mast cell degranulation events. This is also to illustrate that different pathways are involved in activating mast cells that cause different forms of anaphylaxis. So you have the classic eat a peanut, start swelling, going through the IgE pathway, or some individuals actually have, for instance, physical triggers that cause mast cell degranulation, such as cold-induced anaphylaxis. But there are other pathways that can cause this system-wide mast cell activation event. Sometimes you might have an infection that will cause mast cells to release, not only histamine and tryptase, but potentially contribute to interleukin-6 release, which we suspect may be happening in individuals that have exposure to coronavirus and causing long-haul COVID, for instance. So it's important to understand that mast cells can be activated by different pathways. So instead of focusing on what might be triggering the mast cells to release their chemicals, let's establish whether or not mast cells are actually contributing to symptoms such as neurological disorders, constitutional symptoms like chronic fatigue, cardiovascular symptoms like postural orthostatic tachycardia syndrome, gastrointestinal distress, or even joint pain. So in 2010, Cam Icahn, Peter Valent, and Dean Metcalf put forth the first proposed criteria for mast cell activation syndrome, which essentially asks whether or not you have mast cell degranulation occurring in at least 2 or more organ systems. Do you get better with medications that target some of the mast cell mediators, such as histamine blockers, leukotriene blockers, or stabilize the mast cells from degranulation, such as the use of chromones? And then after you ask these questions, these are your symptoms, you get better using these medications. Do you have any data that supports that the mast cells are misbehaving, such as elevated serum tryptase or release of methylhistamine or prostaglandins that are discovered in the urine? So once you determine that someone has mast cell activation disease, it's really important to understand what type of trigger, or what is the phenotypes that are causing the excessive aberrant mast cell activation events. And you can either have a clonal disorder such as mastocytosis or monoclonal mast cell activation syndrome, or you can have non-clonal disorders, which are much more common, such as having allergen-driven mast cell disease, either due to environmental allergens, medications, or foodstuffs. You can have a undiagnosed neoplastic process, or a rheumatological disorder, or a primary immune deficiency that has yet to be uncovered. You can have physical urticarias, which seems to be quite common in individuals that have connective tissue disorders, such as pressure or change in temperature, body temperature, that is. And then you can also, just like any other organ system, develop an antibody to the mast cells in the form of chronic immune urticaria. What I'd like to highlight is that just because you have one receptor that's involved doesn't necessarily mean there's not another phenotype that's participating in your symptoms. And to give an example, this is a report that was put forth by Melody Carter and David Golden in Allergy Immunology Journal, which identified one gentleman who had 4 forms of mast cell activation disease in the form of systemic mastocytosis, allergen-driven mast cell activation, in this case to stinging insects, hyperalpha-tryptophanemia, and he also had meat allergy, commonly referred to as alpha-gal hypersensitivity. So it's important to not only determine whether the person has mast cell activation syndrome, which is a subset of mast cell activation disease, that they have different phenotypes, but you also want to rule out any conditions or comorbid disorders that may also be mimicking mast cell activation syndrome, or potentially driving mast cell dysregulation. And these are some of the conditions that that can mimic mast cell activation disease, including neuropsychiatric issues such as certain headache syndromes, chronic fatigue, inflammatory conditions, as well as isolated disorders such as gluten enteropathy. The importance of identifying what might be causing your mast cells to degranulate or have chemical mediated release will then give an idea of what medications or interventions may be helpful for quieting your symptoms and restoring your health. And of late, there's been a plethora of different agents and interventions that have been shown to help restore the balance between the connective tissue, the mast cells, and the neurological system. You have agents that target the epithelium themselves, such as medicated emollients, traditional Chinese herbal medicine, and the newest monoclonal antibody on the block, which targets a danger signal from the epithelium called tezepelumab, which goes after TSLP. You also have agents that target the interaction between nerves and mast cells. You have agents that target the mast cells directly, or chemicals that are released by the mast cells. And then you have global immunosuppressants that just try to shut down several functions of the mast cells, as well as the communication between other immune cell compartments, such as the T lymphocytes. Unfortunately, even with the criteria of what are your symptoms, do you get better with these medications, most patients end up having an inability to identify a mast cell validated chemical mediator. So as shown by these 2 articles where both of these individuals, Ms. Cohen as well as Ms. Duncan, had undiagnosed mast cell activation disease for years before they were able to get appropriate help. And I have to tell you, I was one of the culprits. Ms. Cohen actually was in my practice and invited me to participate in that article, where I had to unlearn what I was taught during my training, that anytime somebody has a series of reactions, that it is due to the presence of an antibody, immunoglobulin E, that sits on mast cells. And then when you have another exposure to this antigen, that's when you'll end up having these hypersensitivity events. But again, this completely ignores the fact that there are other receptors that can cause mast cells to release their chemicals, as well as interactions between other cell types, including the interactions between the nerves and the mast cells within the connective tissue. And I have to credit, in honor of Women's History Month that's coming up, 3 of my mentors that taught me to kind of think outside of the box. That includes Mariana Castells, who was a major force for the Mast Cell Activation Disease Center at Brigham and Women's Hospital. Charlotte Cunningham Rundles, who's one of the renowned experts on primary immunodeficiency, who's at Mount Sinai, as well as Dr. Shuman Lee, who's taught me to not forget the relationships between the epithelium, the mast cells, and the nerves, with her efforts to try to quiet classic mast cell disorders with the use of traditional Chinese herbal medicine and acupuncture and acupressure. And so, armed with these experiences, I was able to kind of start working with patients, as you see here, individuals that seem to have hypersensitivity in the setting of having evidence of hypermobility. You can see this young lady who underwent allergy testing is clearly hypermobile, and the same thing for this mother and son. And I first met these patients in 2012 when the diagnosis of mast cell activation syndrome was first being put forth. And in order to understand why they might be having such hypersensitivity reactions, I actually resorted to a Dr. Google search and came across this paper by Marco Story, who's a geneticist involved in hypermobility and Ehlers-Danlos syndrome for quite some years. And he put forth this assessment that individuals that have hypermobility have issues beyond just rheumatological issues. You can see that they end up having chronic fatigue syndrome, cardiovascular dysautonomia, pelvic dysfunction. And here they also talk about immune dysregulation, but we really didn't understand that communication until the past 10 years, where we started to see that the mast cells talk to the nerves in the connective tissue all the time. And one of the early observations that I put forth in 2012 with then residents who are now practicing allergy immunology specialists in the community was a series of 10 patients who had evidence of mast cell activation events, but as you'll see, their serum tryptase was unremarkable. Of all these 10 patients, they had symptoms that were worrisome from mast cell degranulation. They responded to medications that targeted mast cells or mast cell chemical mediators, but you can see at the time their serum tryptase levels were, quote unquote, within normal parameters. So they were labeled with MCAS-ish, with hope of more research to try to identify what might be contributing their mast cells to be so problematic. And interestingly enough, all of these patients received the diagnosis of HEDS either from a geneticist or a rheumatologist. So patients, unfortunately, had a long road to try to identify specialists who would be willing to evaluate their susceptibility to hypersensitivity reactions. And I essentially borrowed my experiences taking care of patients with chronic urticaria, as well as non-atopic anaphylaxis, and applied the criteria for identifying mast cell activation syndrome, which is, again, collection of symptoms, response to medications, and do you have any positive lab tests such as serial tryptase measurements, histamine and prostaglandin metabolites in the urine, identifying whether or not there's a mutation in the c-KIT gene, which is found in systemic mastocytosis. And because mast cells are tissue-based, it's important to look at whether or not mast cells are misbehaving in the tissue in the form of atypical clustered mast cells or chronically activated mast cells. These are some of the tests that I would perform or would have reviewed, because a lot of the patients underwent this either serological or biopsy evaluations. And we essentially just revisited a lot of the presented data, or potentially added more testing, especially focusing on immunodeficiency. And I'd like to present some of the work that we've put forth in the past few years, starting with this very interesting observation. I would say this was a study that we had published in 2018 which showed that individuals that had idiopathic CD4 lymphocytopenia, meaning that they had a CD4 T cell count that was reminiscent of HIV infection without having any evidence of HIV infection. And interestingly enough, these 7 patients, who you can see had quite low CD4 positive T cell levels, also had significant mast cell activation disease in the form of anaphylaxis, dermatographism, neurocognitive impairment, upper airway inflammation, as well as headache disorders. Another immunodeficiency that we identified in patients that were having mast cell activation disease were individuals that lacked mannose binding lectin. And mannose binding lectin is a very interesting protein. It is produced by the liver in response to challenges, especially inflammatory or infectious challenges. It is a C-type lectin that contains collagen and plays a central role in innate immunity in the recognition of certain pathogens and also the clearance of apoptotic or dead tissue as well. It's known to target bacteria, fungi, parasites, and viruses, and helps clear substances that have been under attack by the immune system and removing them from the organism, from the individual after they've been able to get that infection or inflammatory response under control. And interestingly enough, the fact that this is the data for the Caucasian population, that at least 7 out of 100 individuals lack this protein. And you can see, again, just like patients who had idiopathic CD4 lymphocytopenia, significant susceptibility to mast cell activation events involving the airway, the skin, the gastrointestinal tract, and interestingly enough, 10% had anaphylaxis. We are now doing the data looking at 20 individuals that have been found to have mast cell activation disease. Nearly 100 individuals that have mast cell activation disease in the setting of mannose binding lectin deficiency. And this is a later poster showing that all these individuals not only had mast cell activation events, 72% of these patients with mannose binding lectin actually had evidence of primary immune deficiency with classic increased susceptibility to infections. And in order to get their symptoms under control, a good number of these patients had to go on to either prophylactic antibiotics or gamma globulin replacement to get their symptoms under control. The most recent study that we have is actually looking at individuals, and we basically who had come through our practice, nearly 1,000 patients, and try to understand their hypersensitivity events. And they were found to have immunoglobulin deficiencies. They were identified for having either hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome. And this is one of the first large studies that identified immune dysregulation in patients that had immunodeficiency and Ehlers-Danlos syndrome. Basically, this patient population were primarily female. The age range is from pediatric to seniors. And what we found was there was a high burden of disease, whether it's gastrointestinal involvement, upper or lower airway disease, as well as common neuropsychiatric manifestations, including headache disorders, general mood disorders in the setting of this chronic conditions, as well as fatigue. And you can see that 19% of nearly 974 patients had evidence of immunodeficiency, mast cell activation disease, as well as hypermobility. So the conclusions from these studies is that immune dysfunction is quite present in individuals that have a connective tissue disorder and evidence of mast cell activation disease. And so I wanted to encourage practitioners and patients to assess if you have Ehlers-Danlos syndrome. It would be important to see whether or not you have an immunodeficiency traveling with your mast cell activation disease. And this is actually an article from the Primary Immunodeficiency Foundation, who also has zebra as a moniker for their specialty. And so I have a tendency now as an immunology specialist to look for connective tissue disorders in individuals that have hypersensitivity reactions and evidence of immunodeficiency as well. So the summary of these studies basically point to the fact that we need a new paradigm for immune dysfunction. This is how we screen for immunodeficiencies with a questionnaire. These are the type of immunodeficiency that have been identified both in the innate and adaptive immune compartments. And it's really important to remember that individuals that lacking certain components, either in the innate immune compartment, such as mannose binding lectin, or in the adaptive immune compartment in insufficient numbers of CD4 positive T cells or antibody levels that are low, that they can present with non-infectious diseases just as much as they can present with either recurrent or severe infections. This is illustrating the different ways that mast cells that can be triggered in both immediate and delayed hypersensitivity reactions. So whether we're talking anaphylaxis, rhinitis, urticaria, or we're talking classic autoimmune disorders such as rheumatoid arthritis or serum sickness, because mast cells have these receptors, they can participate in the perpetuation of these chronic hypersensitivity disorders. And to bring it back to the original conversation on what kind of immune dysfunction that we can see in individuals that have hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome, these connective tissue disorders, per several reports, may be quite prevalent in individuals that are quite prevalent in the general population. And mast cell activation disease is common. And the subset of mast cell activation disease, mast cell activation syndrome, in the form of anaphylaxis, is not too far behind, with 1 out of 50 Americans being reported being treated for anaphylactic event. But these observations make a suggestion that the way that we're seeing this increase of symptomatic hypermobility syndromes, as well as mast cell activation disease, points to the loss of tolerance in our modern world. And it may be very possible that individuals that have hypermobility have increased susceptibility to the exposures that are common in our modern environment, leading to such profound symptomatology. So Ehlers-Danlos syndrome is popular, is common, mast cell activation disease is common, and in the form of aberrant chemical release through several different pathways. And in order to screen for that, this is just a general algorithm that I've put forth to try to understand how you can see whether or not one of your patients has mast cell activation disease. If they're positive, this is the pathway you should pursue to saying that not only do they have mast cell activation disease, but what flavor of mast cell activation diseases they have, so you can optimize treatment and also prognosis. And then you can also, and if they don't have evidence of mast cell activation disease, to encourage looking for another pathology that may be contributing to their symptoms, whether or not it's a primary immune deficiency, a connective tissue disorder, or both. And I just wanted to kind of lean into the investigator that opened the door to understanding the presence of mast cells throughout the connective tissue. So Paul Ehrlich not only was the first to describe mast cells in human tissue throughout the body, he also was one of the founders of modern medicine, where he encouraged the use of trying to understand the basis of disease so that you can then target therapies to help patients get better. And these are some of the therapies that have been put forth, again, in order to help individuals that may have this triad of a connective tissue disorder, autonomic dysfunction, and mast cell activation disease. Whether you're, again, targeting the epithelium so the mast cells stay quiet, thinking that there is not impending danger to the individual, whether you target the communication between the nerves and the mast cells themselves, or you try to just quiet the communication between the mast cells and the cells that can be called in to help perpetuate an inflammatory pathology. And I also want to, again, extend gratitude to Dr. Shuman Lee, who opened my eyes to the communication between the epithelium and the mast cells in trying to help individuals restore their health with the use of traditional Chinese herbal therapy and acupuncture and acupressure. I want to thank you for your attention. I'm happy to provide my contact information if you have any questions. And I hope this conference and this conversation is helpful for connecting the issues in individuals that have connective tissue disorders.